Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. Before we start today, on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to express my heartfelt condolences to all the neurosurgical fraternity around the world at this of untimely loss of the very humble giant and a charismatic academician who left his mark on the map of modern neurosurgery from Ljubljana, Professor Vinko Dolenk. His academic contribution to neurosurgery led to a paradigm shift in the management of skull-based tumors. He was a true friend of ACNS family who had extended his support for the educational ventures on several occasions. We join his family in these difficult times with our prayers. Coming back to our webinars, the speaker for the first session of today is our honorable guest from the USA, Professor Charles Matuk. Professor Matuk is a Vice Chair of Clinical Affairs Neurosurgery, Chief Neurovascular Surgeon, and Director, Neurovascular Endovascular Fellowship at the Yale School of Medicine. He is a cerebrovascular neurosurgeon with expertise in the open and endovascular treatment of vascular disorders of brain and spinal cord. He completed a 2-year clinical fellowship in endovascular neurosurgery and intervention neuroradiology, as well as vascular biology research fellowship studying human vascular endothelial cells in health and diseases at the University of Toronto. He has special interest in treating brain aneurysms, vascular malformations of the brain and spinal cord, carotid occlusive disease, and acute stroke syndromes. He has an interest in general neurosurgery as well, including adult onset hydrocephalus. He has published recently his novel endovascular treatment modality in the form of endovascular shunt for hydrocephalus. We are extremely honored to have him today at our webinars, and today we'll be talking about Lumbocaval Shunt for INPH. The speaker for the second session of today is our honored guest from China, Dr. Li Piliang. Dr. Li is an associate professor, associate consultant in the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. He is a board member of the Medical English Education Association of Neurosurgeons, Chinese Medical Doctor Association, and group member of the Neurovascular Specialists, Shanghai Neurosurgical Association. He has received several awards and honors for his outstanding contribution in neurosurgery in his country, and also has published extensively in various peer journals. We are extremely honored to have him today at our webinars, and today we'll be talking about surgery versus endovascular treatment for anterior cranial fossa AV fistulas. The chair for the first session of today's webinar is an honorable guest from Japan, Professor Shinichi Yoshimura. Professor Yoshimura is the professor and chairman, Department of Neurosurgery at the Hyogo College of Medicine, Hyogo, Japan. Professor Yoshimura was a past president of the Japan Society of Neuroendovascular Therapy. He is a board member of the Japanese Society of Neuroendovascular Therapy and the Japanese Neurosurgical Congress and Counselor of Japanese Stroke Association. He was the past editor of Journal of Neuroendovascular Therapy, and he was the president of the Mount Fuji Congress as well as the Japanese Neurosurgical Congress in the past. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honored guest from the USA, Professor Sabresh Natarajan. Prof. Natarajan is the director, brain tumor, skull base, and cranial neurosurgery, and he is also the consultant in the cerebrovascular and surgical neuro-oncology at the Sharp Healthcare, California. He is a member of the AANS, CNS, as well as the American Association of South Asian Neurosurgeons. He has been rewarded with several awards and honors for his outstanding contribution in neurosurgery. He is a hybrid trained neurosurgeon and specializes in both clipping as well as coiling from aneurysms. He is also a noted author with several publications in various peer journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President of Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Shinichi Yoshimura.
Hi, everyone. I'm Dr. Yoshimura from Japan. So today I'm going to chair of the talk of Professor Matuk. I had the privilege of working with him in the STAR trial, which is a clinical study, primarily based in the United States. And I have a great respect for him regarding his effort in pioneering new works. So today we listen to his talk about Lumbocaval Shunt for INPH. So please start your lecture, Charles.
Thank you so much, and great to see you. And thank you to this Congress for for the opportunity to present. So it's actually the first time that I speak publicly about lumbocaval shunts. And just to give you context, I would say about 80% of my practice or so is neurovascular specific, but about 20% of my practice is a combination of normal pressure hydrocephalus and idiopathic intracranial hypertension and the management of those conditions, which includes pulsatile tinnitus. So this was a technique that we resurrected from the past with some modifications that I found to be very useful in practice. So I'm pleased that you have me talking about it again. It's the first time that I'll actually present this particular slide deck. I have a number of disclosures. I think the most important one from the point of view of this talk is that I am a consultant and proctor for a company called Ceravasc, which makes the endovascular shunt called the eShunt. And I'm the national PI for the upcoming STRIDE trial, which actually just enrolled its first patient last week. So I have no other financial or disclosures that are relevant to today's talk. What we'll do is I'm going to try to walk you through a little bit about how I think about idiopathic intracranial hypotension or hypertension and the treatment options. And then we'll go over the genesis for the idea of the lumbocaval shunt or resurrecting it from the past. I'll be very curious to hear people's opinions on this because it is a general neurosurgical condition, and so I think many neurosurgeons will touch this particular patient population, right? Adult onset hydrocephalus in general terms. Then we'll go through a little bit of the published case series that was recently reported and how I think about incorporating the different modalities in my practice. As we all know, and for trainees that are perhaps more junior on the call, idiopathic intracranial hypertension in the US is a disease essentially of overweight women of childbearing age. There are a few exceptions and a few medical conditions that also predispose to the condition, but by and large, in North America, it's a disease of overweight women of childbearing age. And the main symptoms seem to be a migrainous type headache, where the headache is worse when the patient is lying down or first thing in the morning, which is unusual for headaches, right? And reminiscent of the headaches that you see with brain tumors or when you have raised intracranial pressure. And you can also get progressive visual loss. And at its most mild form, that can manifest as visual obscurations or these transient episodes of blurry vision. But as the disease progresses, you'll have an enlargement of your blind spot, and then you'll have visual field defects, and it can progress in some forms quite rapidly to blindness that's permanent and not reversible. So that is the main symptoms. And then you also have a whole myriad of other symptoms like feeling like you have a pressure in your head or that you're living in a fog. It dulls your awareness or your consciousness because of the raised ICP in some cases. And you can also have pulsatile tinnitus, which is a frequent accompanying symptom to this disease complex. One of the earliest reported features of IIH is that the ventricular size, unlike adult forms of hydrocephalus, are either normal or small. And this seems to be a pretty classical hallmark of the disease and one that was recognized in the 1930s during ventriculocysternography with air, where they were looking for brain tumors or masses in these patients because the symptoms were suggestive of raised ICP, but they couldn't find any particular cause. That led to the terminology or the descriptor of this disease complex as pseudotumor cerebri in the 1930s. Again, referring to something that was tumor-like because of the presentation with raised ICP. In the 1950s, the terminology benign intracranial hypertension began to be used, and that was sort of an homage or a tip of the hat for the fact that the CSF profile in these patients was normal, and so it was like non-inflammatory. But then the term benign didn't sit well with the ophthalmologists of the 1980s, and the name was changed to idiopathic instead of benign, because there is the potential for these patients to have profound vision loss, and so that's not consistent with a benign condition. So today we use that terminology, which is idiopathic intracranial hypertension. There are two pathophysiological mechanisms that have been discussed in the context of IIH. The classic one, which has been around for many years, again, since the 1930s, is increased CSF production. And the way that would then be treated is with drugs to decrease CSF production, the common one being acetazolamide, which is a carbonic anhydrase inhibitor, or to divert CSF out of the cranium as a way of impacting the fact that there's perhaps increased CSF production. More recently, people have thought about abnormally high dural venous sinus pressures as potentially implicated in this disease process, and treatments are then directed at alleviating those high dural venous sinus pressures and the venous sinus stenosis that often comes with it. So in this particular case, and we'll talk a little bit more about this in a little bit more detail, there's different ways that the dural venous sinuses can be pressurized in this condition, and they'll have different treatment implications about how we want to address that particular type of IIH. So those are the two sort of competing pathophysiological mechanisms, and there's probably some that are more the result of one of the mechanisms and some varieties that are more of the other. So in terms of definitions, we use the modified Dandy criteria by and large, which are enumerated over here. But basically, you have symptoms and signs of raised ICP, a lumbar puncture that's usually greater than 25, but can be greater than 20 if it has another accompanying feature. You have absence of any localizing or focal signs on a neurological exam. Then the ventricular system is again normal, so it's not enlarged, it's not obstructed or displaced. And then the neuroimaging is by and large normal, except for the indirect stigmata of raised ICP, which is the empty sella turcica, dilated optic nerve sheaths, and a smooth-walled venous sinus stenosis. The patient should be awake and alert with no alteration in mentation or consciousness, and that there's no other identifiable cause for raised ICP. So that's the classic sort of definition and criteria for IIH. But there are a competing, set of criteria that are based on this new venous pathophysiological model, and they could be enumerated as the craniocervical type, which has to do with like a focal stenosis in the region of the transverse sinus. The central type, which is usually in obese patients, where you have increased central venous pressures that are transmitted intracranially. You have a mixed type, where you have a combination of both the focal transverse sinus stenosis and the high central venous pressures. And then you have a type that's related to resolution or near resolution of venous sinus thrombosis. So there are different ways to categorize these diseases, and they have different treatment implications. For example, in the craniocervical type with the focal transverse sinus stenosis, a stent might be a good choice, Whereas if you have high central venous pressures because of morbid obesity, then weight loss and medications like acetazolamide might be a better first-line management option. So how do we think about treating IIH? And I think this is sort of an evolving subject as our understanding of the breadth of the disease process becomes better understood. But the classic way that it's taught is that all therapies are directed towards vision preservation, right? So the worst thing that can happen is to have somebody lose a significant amount of their vision, or in worst cases, go blind. You wouldn't believe it unless you see it, but it is very real. And we've had patients in my practice that have come in with what they call fulminant IIH, which is rapidly progressive vision loss, usually over the course of days or hours. And those patients can lose their vision permanently. And so it really is not a benign condition from that point of view. So we distinguish between if the vision loss is either slow, which is the chronic form, or whether it is fulminant, which is the more rapidly progressive and severe form of the disease. So in chronic IIH, where the vision loss is slow and progressive, the mainstay of treatment is weight loss and acetazolamide. And then if you have patients that have progressive loss despite best medical management and weight loss, or they're unable to tolerate their medications, or they continue to have significant papilledema on fundoscopy, then those are patients that can be considered for surgical treatment. Whereas in the fulminant form of the condition, you really don't have time for weight loss or medications. And these are patients that would have urgent or emergent surgical interventions, broadly speaking, either in the form of CSF diversion or venous sinus stenting. So there's two recent meta-analyses that were performed on the benefit and the limitations of CSF shunting and venous sinus stenting, which are the two main forms of surgical intervention for this condition. And I'm just going to summarize here the systematic review and meta-analysis from Chris Ogilvie at Beth Israel and Harvard, his group, put together on CSF shunting and its role in the surgical management of patients with IIH. And what you'll see is that in terms of their headache syndrome, there really is substantial improvement, especially in the short term after shunting. And that can be either in the form of ventricular shunting or in the form of lumboperitoneal shunting. You have significant improvement in a vast majority of patients in terms of their papilledema and stabilization or improvement of vision loss. But the big problem with this particular type of surgery is that the revision rates are extremely high. So nearly 50% of these shunts will have a surgical revision, and many patients will often have multiple surgical revisions over time, and it can really become quite a debilitating condition. When you have a ventricular shunt that's in place, the big problem is the size of the ventricle. So just to go back to that little insert, you can see how small the ventricles are. And even if you're able to successfully cannulate the ventricles, which we usually can using either craniomorphic markers or with neuronavigation, the ventricle into which the catheter is inserted often collapses and obstructs the little holes in the side of the ventricular catheter. And so you get this pseudo-obstruction picture and a recrudescence of the patient's symptoms. And so then they'll have these episodes of like the headache gets worse because of the pseudo-obstruction, the ventricle fills back up again, they feel better, and then the CSF drains and the ventricular walls collapse again around the ventricle, and you get into this vicious cycle where they just don't feel well or their headaches come back. This often results in multiple revisions because we think that the shunt is obstructed, and of course sometimes it is. And so that often leads to multiple revisions, and it's very frustrating for both and debilitating for both the patient and, to be honest, the surgeon. So of all the types of adult conditions in which shunts are required, so after subarachnoid hemorrhage or trauma, after normal pressure hydrocephalus. This population is definitely the population that is the most difficult to manage with a ventricular shunt. The problem from a lumboperitoneal shunt point of view is that they get obstructed or need revisions just as frequently, but often they'll require many more revisions, than a ventricular shunt. So the rate of having a first revision is the same, but that first revision often leads to multiple revisions. And the other issue, of course, is that it's a closed box, is to interrogate the shunt. Unlike if you have a programmable valve or a reservoir, you're really sort of in a closed unit, and any interrogation of the shunt really requires redo surgery. And so lumboperitoneal shunts can also be very difficult to manage as in the outpatient setting for these patients long term. So does venous sinus stenting do any better? Well, we'll just focus on the bottom number. I should have written here stent revision rate. This is usually from an in-stent stenosis, is much, much lower than the nearly 50% in terms of shunt revision surgery. So that's much better. But the problem, and their papilledema improvement is also similar. But the problem, of course, is that their headaches don't seem to be as improved, especially in the long term. And I think this was nicely reinforced by this recent paper out of Kyle Fargan's group at Wake Forest that showed that the clinical outcome post-venous sinus stenting is that there's often initial symptomatic improvement followed by symptom recurrence in more than half of patients at the 1-year mark. And if you re-LP these folks, they don't have raised ICP. And if you do fundoscopy on these folks, they don't have recurrent papilledema, and so which stays controlled in over 3/4 of patients, and at least in this population. This very much rings true with my practice of these patients in terms of the venous sinus stenting, where initially they're very pleased with the results, but within a few months to a year, many of their symptoms recur even without an in-stent stenosis or an adjacent to the stent stenosis, which we often see. So it is not the sort of like, as any new technology or new innovative surgery or procedure, there's this initial, excitement after the inception. And then the excitement wanes as reality sets in, and it's not the cure-all for everything, and you get this sort of period of disillusionment. And then, as time goes on, we become wiser and learn what the right patients are to treat with these different procedures, and how to modify the procedures so that they're safer and more effective. So I think right now we're sort of on this very high period, but we're starting to see some cracks in the seams of venous sinus stenting in terms of being a solution for all folks. So now we're going to talk a little bit about the concept of the lumbocaval shunt. So while all this was sort of going around in the background, that I was treating venous sinus stenting was emerging, and I was trying to figure out how to incorporate this into my surgical IIH practice, we were able to recruit the eShunt pilot study for NPH to Yale. And so just to level set for this particular audience, what this particular device does is it tries to effectively replace or recreate an arachnoid granulation, which is the anatomic structure through which CSF is absorbed back into the venous system down a gradient, where the pressures in the CSF are essentially always higher than the pressures in the vein. So it's down this normal physiological gradient. And this is a picture here of the device, and it's very simple. If you see here my arrow, this is the part of the device, this little crown, it's called a malacot, that sits in the subarachnoid space in the region of the CP angle, so right at the skull base. And there's a little hole here that's protected by this metallic crown, and then this piece of plastic, which is the shunt itself, at the bottom of which is a slit valve, and that has two functions. One is to regulate the amount of CSF that's flowing out of it to about 10 cc's per hour. And the other one is to prevent reflux of venous blood into the CSF space during, for example, a Valsalva maneuver. And so this now essentially recapitulates or is a biomimetic for a naturally occurring arachnoid granulation, and is thought to potentially now be an endovascular solution for a ventricular peritoneal or shunt or CSF shunting in general. And the way that this device is placed is that it's, you put up standard guide catheters through the internal jugular vein. And the internal jugular vein at the skull base divides into two main branches, the larger sigmoid sinus, which you can see illustrated over here, and then a smaller inferior petrosal sinus, which will go up and join the cavernous sinus along the skull base. And the device is essentially going to be delivered through a delivery catheter, at the tip of which is housed this very sharp needle. And the needle can then be used to push through the wall of the inferior petrosal sinus and the dura into the subarachnoid space of the CP angle. And through this delivery catheter with a needle housed in its tip is delivered the E shunt, that endovascular shunt, such that that crown that we talked about, or the malacot, sits over here in the subarachnoid space, and then that long shunt tubing will go down, the tip of which will sit in the distal internal jugular vein and create a fistula, essentially, between the CSF space and the venous space. So Pedro Lilic, who many of you might know, in Argentina, did the first in-human study, and it happened to be in a patient with aneurysmal subarachnoid hemorrhage. And essentially here, this was an elderly woman who had a ruptured MCA aneurysm. The aneurysm was coiled successfully. She had an EVD that couldn't be weaned. And so when they clamped it, the ICPs were up between the 35 and 40 mark. They then went on to avoid needing a shunt to place an E-shunt device. And what you can see is that really within minutes to hours, the ICP fell precipitously to essentially a normal level, right? So here it's 0, and stayed in the 10 to 15 range over the course of 36 hours, and then the EVD was successfully weaned. And so this is essentially the physiological proof of this concept that if you can create a fistula between the CSF space and the venous space, you can mitigate raised intracranial pressure. Pedro has since done this a number of times in Argentina in the subarachnoid population, and very consistently and reproducibly, you can have sustained ICPs with a clamped EVD that are then normalized essentially here across 8 patients in total. I think that they're trying to work up to 20 patients, but the results have been incredibly consistent. Again, proving this idea that if you can create a fistula, a biomimetic for the arachnoid granulation, that you can control raised ICPs in this population. So in the US, the first disease state that was going to use the E-shunt was normal pressure hydrocephalus. We placed the first E-shunt in the US in a patient with normal pressure hydrocephalus back in August of 2022. And here you can see me and my team, and this is the needle in the subarachnoid space beyond the superior wall of the inferior petrosal sinus, and the shunt being pushed out. Here you can see the E-shunt on a Dyna CT with the malacot properly positioned, this crown at the mid-level of the jugular tubercle, at the skull base. So we're very proud to be involved with this technology, but again, like in the subarachnoid hemorrhage population, what we see in the normal pressure hydrocephalus population is that in terms of their gait stability, and their walking speed, here assessed by something called the timed up and go test, the tug test. You had a significant improvement, which is this decrement here. We had a significant improvement that was sustained over a year in their walking speeds compared to normal when you have an E-shunt that's placed, which is very similar in my practice to what I would expect to see with a ventriculoperitoneal or ventriculoatrial shunt. So it seems now that there's a mechanism by which we can, if we create this CSF to venous fistula, that we can mitigate the high pressures or the hydrocephalus in a patient's brain. Now, there's all kinds of reasons for why an E-shunt is not able to be implanted. And one of the reasons is that the IPS travels in a bony groove or tunnel at the skull base. And sometimes that groove has a lot of overhang, bony overhang. Sometimes, in fact, it's not a groove, but it's a bony tunnel. And that will obviously not allow a needle to be penetrated into the subarachnoid space through bone. So that's one reason why an E-shunt can't be placed on anatomical grounds. A second reason is that sometimes the IPS is not one channel. It's actually 3 or 4 smaller channels that look on cross-sectional imaging like one channel. They're blurred together. And you need the caliber of the IPS to be a certain size for the mechanism that unsheaths that distal needle to work properly. So that's another reason. And the third and most important reason is there can't be any arterial structures in the planned puncture path of the needle. So if there's a loop of ICA or the basilar artery swings towards that particular IPS, that would be a no-go for E-shunt. And we think that about probably 40% of cases, at least in the MPH population, are not going to be candidates based on those current criteria. So is there a way, we were thinking, to recapitulate what we can do with an E-shunt or what we can do with a ventriculoatrial shunt, which is create a connection between a CSF space and a vein, and avoid some of the issues and complications that we have with the traditional treatment strategies? Because it seems like the headaches in general are better controlled with a shunt if it were not for the fact that the ventricles collapse on the ventricular catheter and you get this issue with regard to pseudo-obstruction or frank obstruction of the catheter. And so as we were thinking about this, it was really stimulated by our first patient, and we'll talk a little bit about that patient in a moment. But it was really he and his family that came in with a very convincing condition and a very convincing story that made us start thinking about, well, how can we reproduce in some way, the E-shunt using tools that we have at our disposal. The E-shunt obviously can't be placed as well for idiopathic intracranial hypertension in the United States or anywhere in the world. Unless it's done under compassionate use, which here in the US would mean applying to the FDA for a compassionate use exemption. So what we figured was we want to stay out of the head because of this issue of ventricular collapse in the small ventricles. And we want to put it into some venous system. As an endovascular person that also does a little bit of surgery, we thought this would be a potentially very elegant solution to place it in the femoral vein and to float it up the inferior vena cava where it joined the atrium, the right atrium. And so that was our concept of the Lumbocaval Shunt. And we then went and looked back at the literature and we found that there were similar reports. This is the first report of what's called a lumboatrial shunt, where the venous site was actually the internal jugular vein. So they ran it from a lumbar position and then they went up the chest wall and then put it into the internal jugular vein. And that was back in 1983. And since that time, there's only been a few case reports, 2 of which have involved placement inside the femoral vein, in the early 2000s. And so our version of this technique basically involves starting off in the prone position and angling a spinal needle, just a little bit off of the midline, and angling it in a way that the drain will insert nicely into the thecal sac at about the L1-2 or L2-3 levels. And then tunneling that catheter. So we would secure the catheter using little silicone dips to the fascia so that the catheter that's now intrathecal or within the spinal subarachnoid space doesn't get displaced or moved. And then we would tunnel that catheter in through the subcutaneous tissues to the patient's flank. And then here you can see over this flank, we would create just a small little pocket, and then we would place the catheter that is now tunneled from the midline into this little pocket. We would close it temporarily, and then turn the patient supine, and then complete the passing it to this sort of like nipple line incision, which will be essentially now perpendicular to your femoral venous access site, so that if you have any gravitational units or for proper functioning of the valve, that those are situated perpendicular to the floor, and so that they work properly. It's important when you do this tunneling, especially in obese patients, that the tunneling occurs close to the fascia, because if you put it in the redundant subcutaneous tissues, that movement we've seen can move the catheter quite a bit and can even fracture the catheter because of this sort of repetitive pull trauma to the catheter tubing itself. It's then inserted using standard percutaneous techniques into the femoral vein, and that is then navigated through a peel-away sheath to the junction of the inferior vena cava and the right atrium. And that's essentially the completion of the procedure, and this is what the catheter would look like. You don't want this here, we've learned over time, you don't want this kind of harsh angle. I think that may or may not become a problem at some point. So we make it more of a curved angle by having it sort of like dip down and sort of sit more in this way. So there's a little bit of like, learning curve to this stuff and learning what's important and what's not important. It's also important to place this thing high enough that if you need to do a lumbar puncture at L4-5, that you're still able to access that space safely under fluoroscopy without puncturing or damaging the tubing. So that's sort of iterated over here in writing. If you guys have this video saved. So in terms of like the first patient that we did was back in October 2023. He was a 30-something person or patient with long-standing IIH for over 20 years, had multiple shunt revisions, ventriculoperitoneal, ventriculoatrial, lumboperitoneal, and always had transient improvement, and then the effect was very short-lived and waned. He came to us most recently after a revision ventriculoatrial shunt became infected with P. acnes and had to be removed. We placed a lumbar drain to try to mitigate some of his symptoms, which were really quite severe at the time. So his pressures were up in the 50s when just kind of like walking around. Main complaints would be things like severe debilitating pressure headaches, doesn't allow him to really get up and around. And this sort of like fogged sensorium where he's, not as sharp as he should be, not really able to participate in life with his family. So really very, very debilitating from just a quality of life point of view. And he had obviously multiple opinions from multiple specialists, came to us, and we thought maybe we could do a venous stent, but when we did manometry and looked anatomically at the venous sinuses, the dural sinuses, they did not have an anatomical stenosis. They did not have a physiological gradient on testing, on invasive testing. And that's an important actually point where sometimes you can have a physiological gradient, but you don't see an anatomical stenosis. So it's important to test in convincing cases. We evaluated him for compassionate use of the E-shunt, but unfortunately didn't pass on clinical grounds. And then with the lumbar drain that we placed, we proved that his symptoms really nearly resolved with effective lumbar drainage. And so this was the first patient that we placed a lumbocaval shunt in. And I would say, shocked by his level of improvement, having treated many of these patients. Interestingly, he's not obese at all. So he has, some variety of IIH that's more pure than the average person in North America. But he's really enjoyed sustained relief without the need for any type of shunt revision surgery. I've rarely had a patient that's been as thankful as he and his family, for the benefit that is deriving from this procedure. And really, they get the credit for, pushing us to think of this type of solution, which really has been, very effective for that patient. We've since done this in about 12 patients, and we've gone through a learning curve where, again, we've had one shunt that we didn't secure to the fascia migrate and had to be revised. We've had a patient come back with low pressure headaches where we had to redo surgery to add a gravitational unit. But what I will say is that, consistent with this observation that the headache syndrome seems to do well in patients that are shunted, especially if you compare it to the venous stenting population, they do better. If it were not for this collapsed ventricles issue, that these patients really have sustained benefit in terms of their headache syndrome, which for many of these patients is actually the problem, because they don't have papilledema. They have a form that doesn't present with threat to vision, but it's more these sustained raised ICPs that cause brain fog and headaches that leads to the poor quality of life. We've been very pleased so far with the results in this small series, which again, I think recapitulates what we would see with the E-shunt, which I also think will be a very useful tool when it becomes available for use in the IIH population. So when I'm dealing with patients with chronic IIH, I tend to divide them into two groups. So we're going to remove the group that has fulminant IIH that presents with rapid, severe vision loss. Those patients need either to have a lumbar puncture or a lumbar drain or urgent surgery, either in the form of a venous sinus stent if they have clear evidence of stenosis and a physiological gradient on manometry, or you just put some kind of shunt in. That's the management of that particular condition. But in the more common population, the much more common population that has no papilledema but has raised ICP, indirect stigmata on MRI, and really it's the headache syndrome that is driving this whole process. If they have pulsatile tinnitus and are amenable to venous sinus stenting, because they have pulsatile tinnitus, I'll do that first, because pulsatile tinnitus is very responsive to transverse sinus stenting. But if their dominant syndrome is headache and pulsatile tinnitus is not playing an important role, we are now placing lumbocaval shunts. Again, we're early in our experience, but we're excited so far by what we see. I think I'm going to stop there, and I'm happy to answer any questions.
Thank you very much for your wonderful presentation, Charles. I think people are very interested in your presentation. Before that, I have some questions for you. So I think that diagnosing intracranial hypertension itself seems to be difficult. How can we diagnose it? Because pulsatile tinnitus and headache are very common symptoms. So checking papilledema was something the important finding to diagnose the patient.
Yeah, it's a great question. And it is such a challenging patient population. And I think it exists on a spectrum. And I think what we were taught as neurosurgeons was sort of an extreme form of what is probably a much broader condition, in the sense that, of course, there are patients that present with papilledema and vision loss. And by the way, I think it's important for the trainees to recognize that papilledema is a necessary intermediate to vision loss. So if you don't have papilledema on fundoscopy, you don't have to worry about loss of vision. You can reassure the patient that they're not going to lose their vision if they don't have papilledema on fundoscopy, because that's the mechanism by which vision loss occurs. But in our population in North America, if we have patients that have positional headaches that are worse when they're lying down and have a normal MRI, I think that it's reasonable at that point, and you send them for fundoscopy and make sure they don't have papilledema. It's reasonable to put those patients on a trial of acetazolamide and see if they get better, without even doing a lumbar puncture. My practice is that I really like the lumbar puncture because then is the pressure high or not high? And of course, there's going to be situations that are, in between the cracks. So if you have a patient that has raised ICP that's chronic and now has anterior skull base erosions, or maybe a CSF leak like rhinorrhea or autourea or something, some kind of CSF leak, or just erosions at the skull base, he's actually treated himself for the raised ICP by creating a passage for CSF to get out of his head and mitigates the raised ICP. So in some of these patients that have this dual issue of CSF leak and raised ICP, when you do a lumbar puncture, you might not actually see the raised ICP, even though they have it. It's just being obscured by the fact that they have a CSF leak. But I think high suspicion in a patient with positional headache in our population in North America, obese women of childbearing age, there's certain medications like vitamin A that are associated with it. So you want to do a quick drug screen, send them for an MRI, look for indirect stigmata on the MRI scan of pseudotumor, like empty sella, like dilated optic nerve sheaths, like descent of the tonsils. And then if you need to, do a confirmatory LP to make the diagnosis. But that's in my head how to do it. Shunting and venous stenting, if you see a patient like that, should be the last thing that you're thinking about, because 90% of those patients will improve on medications or with weight loss.
Okay, thank you. Any questions or comment from the audience?
Yes, we can take comments and questions. Yes, Dr. Liu, any questions from your side?
Q&A. What are complications of the cable shunt? How you know it's working or not? This is a question from Dr. Parek.
It's a great question, and maybe I'll start with the complications that we've seen. We've had a catheter migrate out of the spine and into the pocket above the fascia in the back. And if you have to secure it, we've learned that you have to secure it well with little silicone butterfly pledgets, and secure it to the dura will help, I hope, prevent that particular problem. We've also seen a patient, if you make the catheter too long, that have palpitations or arrhythmias. You don't want to make the catheter so long that it tickles the atrium. So, it has to be long enough that it's not going to move out. So that's a second problem that we've seen. The third problem that we've seen is fracture of the catheter. If you make the passage of the catheter not really against the patient's like fascia, but you make it more in their fat, then the fat jiggles so much that it's moving the catheter. We didn't really appreciate that up front. So you don't want to put it in the superficial tissues. You really want it to be, deep, closer to the main part of the body. But we haven't seen venous sinus thrombosis. I haven't seen one become obstructed yet. And I'm sure we will, of course. But so far it's been good. How do you know it's working? I think, like anything with shunts, the best clue is that the patient's symptoms are better. If the patient's symptoms come back, you do have to worry that, how do you evaluate the shunt? And probably the best way to do that is to repeat an LP and document the opening pressure. And if the opening pressure is low, then the likelihood, I think, is that the shunt is working. And just remember that when you put in a ventricular shunt, because these patients will have collapse of the ventricle walls around the ventricular catheter, you often cannot interrogate the shunt like we do in a standard way, because you will not be able to pull back or inject fluid through the shunt. And so even though we can assess it, you can't really assess it because of this issue of the ventricles being so small.
Okay.
Yeah.
Thank-
Hello.
Okay, go ahead.
Yeah, hello, Professor. Sorry.
Hey.
Thanks for a nice lecture. I have a three short question, Professor. Regarding the lumbar puncture, would you think that there is just a single reading, or we need to do the traditional 24 hours monitoring to look at the pattern of pressure, and whether you think that lumbar pressure and cranial pressure are the same? In what position a patient should be? My second question, Professor, in your series, there's 1/3 of them are male. Is there any similarity between the male and female? My last question, Professor, in terms of emergency treatment, do you think that the optic nerve sheath fenestration is still a necessity? Thank you, Professor.
All right, thanks for the thoughtful questions. We've tended to only do one lumbar puncture, large volume lumbar puncture reading if we can get CSF out. So we don't do the more elaborate testing for this population. It's done in a left lateral decubitus position. You don't want to do it prone because that will create spurious results in terms of the opening pressure. And I agree, there are going to be some times, especially if there's strictures or obstructions, where the cranial pressure and the lumbar pressure don't correlate. But I think in the majority of patients, that is going to be true. If you are worried about that based on imaging, we have on rare occasions placed an EVD in patients that have extreme phenotypes and that we really think would benefit from a treatment. But that is, I would say, rare. In the NPH population, which is like a whole other conversation, we do both large volume punctures and we do inpatient 3-day continuous lumbar drain trials. I find in most patients both to be effective. And there's certain scenarios which we can get into another time about why I would use one versus the other. So that's about LP and the cranial versus lumbar and the position. In terms of optic nerve sheath fenestration, I purposefully didn't talk about it because we in Connecticut, believe it or not, do not have a person that does optic nerve sheath fenestrations. And so just from a practical point of view, it's not part of my algorithm. If you have a patient that really has isolated papilledema and the headaches are not importantly contributing and he does not have pulsatile tinnitus and he doesn't have brain fog and all these things are true and it's really an isolated vision issue, I think in theory those patients would benefit from a fenestration, although my review of the literature suggests that those patients still have significant visual impairment after the fenestration. That might be more to do with the fact that I think that procedure was more performed, at least in North America, in my region, historically, and the expertise has waned, kind of back to when the people that taught me neurosurgery were doing 2 or 3 bypasses a week, and now an institution is doing 2 or 3 bypasses a year. It's like at least in my neck of the woods, right? So it's just like a different time and a different level of comfort with what is probably a good procedure. What do you guys do? Is that like an option for you guys?
No, we hardly practice that, Professor.
Okay, yeah. Yeah, we don't have much of it. And the few times that we've tried to send folks, first of all, that patient demographic is very rare, right? The much more common one is they're complaining of bad headaches, right? And then headaches and papilledema, and then you convince them that the papilledema is gone and you have to manage your headache symptomatically. But it's very rare for someone to be fine and have just optic nerve issues, in our experience.
How about male in your series, Professor?
A male. So there's no question that in North America, it's a disease of women, right? By and large. We do have men, and the men tend to be normal weight. And so there is a different pathophysiology that is difficult to understand. Anecdotally, I would say that the patients that are morbidly obese, in particular, don't do as well. And I think that there is a strong association with psychological chronic illness issues, the weight, there's the very high central venous pressures that you might not lead to effective drainage, right? And so I think that that particular population is extremely challenging, especially without weight loss. Is the demographic similar where you live in practice?
Yeah, we don't really collect data on that, but as usual, the female are the dominant. But in your series, I think it's quite high. Male is 33%. So that's why I am asking this. Thank you, Professor.
Yeah.
Thank you.
Well,
Thank you.
just a
Bas?
quick question. Great
Yes,
talk. How do you today, with all of this data, especially coming out with venous sinus stenting, decide who do you venous sinus stent versus shunt? Do you still venous sinus stent with patients having recurrent symptoms? It's ICP a bigger thing to control? If patients are having headaches, can we treat them with other thing and still do the stenting? How do you choose these patients in your practice?
It's a great question, and it's one that the answer is evolving, right? So I found in my practice when I started, so Joe Piepmeyer was our sort of tumor skull-based surgeon here for many years. He had a side practice of IIH, and when he retired, I sort of took that over. And frustrated with these shunts, right? Because the patients are, their papilledema is often gone, right? But they're often miserable because they have all the other symptoms that aren't better. And so when venous sinus stenting came along, I jumped on it. I was like, anything's got to be better than this. And then, of course, like anything, then we started to see that, like, yes, the papilledema gets better, and yes, things improve for a few months. But then many patients come back, I find, with recurrent headaches. And my impression was that it was more often that they were coming back with headaches and some of these other symptoms, with or without new in-stent or adjacent stent stenosis after venous sinus stenting. So the papilledema was very well managed. If you re-LP'd them, their ICPs were very well managed, but somehow their headache syndrome didn't improve, and then you kind of dismiss them. But it seemed to be at a slightly different rate than with the shunts, if you can get the shunt to like work and behave itself. And so now what I do is that if a patient has a pulsatile tinnitus as a dominant feature, pulsatile tinnitus really goes away with stenting. So that's like house money. So if they have IIH and dominant pulsatile tinnitus, I put a stent in. But if they have a dominant headache syndrome and IIH, I tend to now place these lumbocaval shunts. And that population is much larger than the group that has dominant pulsatile tinnitus. So I'm a little bit of an outlier, I think, in the US from the folks that are on the podium talking about this. But that's just been my real world experience.
Yeah, I practice more of venous sinus stenting. And then if patients have recurrent symptoms that are disabling, then they get a shunt as the failure of the venous sinus stent therapy. It's interesting that you're skewed on the other side.
Yeah. Yeah. Yeah, I think that I wasn't when I was putting a ventricular shunt in, but now with this lumbocaval thing, I mean, problems will emerge, right? It's still very early days, and we'll see what the issues are. But so far, I've been very pleased. I've been very pleased about not being in the head, not being in the ventricles. And if you choose patients, I think that are not very bogged down by the psychosocial elements of that disease, that you can really see. We've had transformational improvement in some of these patients.
Thank you very much, Prof. Just one quick question that I would like to ask you is like, you are obviously puncturing a venous sinus on patients after heparinization. Why haven't you seen an intracerebral hematoma so far?
You mean with E-shunt?
Yes.
Yeah. There's almost been 100 E-shunts placed globally. So the most of them placed by Pedro Lilic in Argentina. We're the second highest group, worldwide, and we have never seen a hemorrhage, ever, after dural sinus puncture in this procedure. And the reason is that there's a physiological gradient. So the blood can't bleed up a gradient, right? The venous pressure is lower than the CSF pressure. So it can't bleed in that direction, which is what we see clinically. But it takes a fair amount of, you know, courage, the first few times you do it, because it does seem crazy. But now it's been done, almost 100 times, and there hasn't been that particular issue.
Thank you. Thank you very much. One short question again. What is your longest follow-up?
For the Lumbocaval Shunt, the first one that we placed was October 2023, so it's just a little over a year, almost a year and a half. And then for E-shunt, it's about two years now, I think, are the longest follow-ups.
Okay. And one about you said if the patient had pulsatile tinnitus, you would give a trial of acetazolamide when there is no papilledema. So, like, what is the dosage that in your patients?
So there's a trial called the
Nordic trial, you mean?
Yeah, the NORD trial, the IIH treatment trial.
Yes.
And basically what that showed is that if you have mild papilledema and IIH, that the majority of patients will improve on medical therapy and a salt-restricted diet, like so weight loss. And so if there's any message that can be communicated, I think, to this audience is that the overwhelming majority of IIH is treated medically, that they will never get to a surgeon or an interventionist, nor should they. And so that the vast majority of patients will be managed by the ophthalmologist, because they come in with a little bit of papilledema, and that's who follows them routinely. It's only when those measures fail or they develop side effects from the drugs, and now there's multiple drugs that you can use to lower the dose of acetazolamide, because many of the drug complications are dose dependent. That it's rare, in fact, that they get to you. And so when they get to you, it's already, hopefully, that they've tried many things and dose escalation and multiple drugs and and they still either have papilledema, progressive vision loss, or a worsening headache syndrome that's impeding their quality of life.
Yes, I think the newer one, the semaglutide, is seen as a potent drug for
Yes.
IIH also.
I think that's going to be potentially revolutionary in this country for this condition. But again, like anything, we're now that people have been taking that drug for a while, we're seeing issues, right, emerge. As
Yes.
they get, rebound weight loss when they come off the drug, and well, what does it mean to be on a drug like that long term? And nothing is. I'll often just say that if 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 we knew the right answer to some of these questions, everyone would be doing the same thing, and there would be no heterogeneity. We would all just be doing the same thing because the answer would be clear. And I'll say that, just to use an analogy from endovascular, if you want a more trackable wire or catheter, it's going to be less stable. And if you want a more stable catheter or wire, it's less trackable. You can't have everything. with one treatment solution. So there's going to be nuance to anything.
Yes, thank you, thank you. So that by that we'll come to the end of first session. I will give this podium to our Honorable Chair, Prof. Yoshimura, to hear his concluding remarks.
Yeah, I believe there are still many questions, but we have run out of time. And thank you very much for your wonderful talk regarding a new treatment for a patient. Charles, I think we will close this topic now. So thank you all.
Thank you very much. So I'll hand this podium over to our second chair, Prof. Natarajan, who will say a short introduction and invite Prof. Pilian for his lecture.
Thank you for inviting me to chair this session. Here always to support ACNS and its educational efforts. This is a topic of great interest with anterior dural fistulas, as Charles has said in a lot of things. There's not one way, and as we evolve, we think about different ways of doing these things. Classically, the teaching was an anterior dural fistula, you do a surgical, resection or obliteration. But today we are doing a lot of transvenous cases for arteriovenous malformations and fistulas. And I think that has changed our ability, techniques, catheters, and what we can do through the venous compartment for these fistulas, and even catheterized through the modal feeders. So I invite Professor Pilang to give his talk and see how he would advise us to manage these patients.
Thank you, Professor Natarajan. I'm very glad to share my personal experience on how to choose the treatment method in anterior cranial fossa DIVF, microsurgery, or endovascular surgery. And this is not very common disease in all the neurovascular diseases, but it's always presents with the intracerebral hemorrhage or sometimes subdural hemorrhage. So it is easy to be confused with other spontaneous intracranial hemorrhages. And just like Professor Natarajan said, many years ago, my teachers, when they did this kind of surgery, they usually like to use the epidural approach to cut all the feeders from the cribriform, and they usually facing a huge amount of hemorrhage during the operation, usually 7 to 8,000 hemorrhage in a single operation. But after that, many years later, when we facing this kind of surgery, we found that we can do it more easily, and that's because the understanding of this disease become more and more clear. So I think the key to manage the fistula is to understand the structure of this kind of disease. So it is very easy to describe this disease. That is, for DVF, it's just a direct connection between artery and veins on the dura. So the key things we need to address to how to well deal with this kind of disease is know the feeding arteries and the drainage veins. So in this kind of anterior cranial fossa DFF, the feeding artery is special. It's mainly from a branch of ICA, ophthalmic artery, and that they are anterior and the posterior ethmoid artery, and sometimes they may come from the MA or internal maxillary artery or STA. But all of them may give rise to feeding artery free of the facts. Superior decided how to choose the treatment method of this kind of disease. The feeding artery originates from ICA makes it hard to the safe distance for reflex is very short, and you cannot allow the onyx to reflect too much. Otherwise, they will enter the ICA. And the small caliber and the tortuous course of these feeding arteries makes the onyx very difficult to diffuse to the fistula. And also, the central retinal artery shares the same main trunk of the ophthalmic artery. So, if the embolic agent diffused to this kind of artery, this will damage the patient's vision. But on the venous side, the structure is really very, very simple, and they always drainage to the cortical vein, and they are corneal type 2 or corneal type 3 or 4. So this is a picture I drew from. The feeding arteries is tortuous in the scene, but we can focus on the drainage vein. So the arteries is the pitfall of the treatment, but the vein provide us the advantages of the treatment. So let's review the DAVF classification. So corneal type 3 or 4 DAVF has a simple structure, easy for microsurgery, but they also are very dangerous disease, need to be treated. So this is the pattern of the type 3 or type 4 DAVF. So we just need to cut the drainage vein and to achieve a cure of the disease. So again, for the anterior cranial fossa DAVF, it's hard to super select to the feeding arteries, but easy to disconnect the drainage vein. So my treatment principle to this kind of disease is to first and also very most important thing is to choose according to the classification. So in Huashan, the surgical disconnection of the fistula is usually the first choice. So this is a very typical case of anterior cranial fossa DAVF. It presents with intracerebral hemorrhage of the frontal lobe, and later it developed a subdural hemorrhage. And we can see the feeding artery comes from the Felsen artery, which originates from the left STA, and also the bilateral ophthalmic artery gives the feeding artery to this fistula, and then VAs. So to this kind of disease, I would like to spot here to see the picture. I usually put them on the supine position, but the head will turn a little bit to the ipsilateral side of the drainage vein, so that the brain tissue could be retracted by the gravity. And after I open the scalp flap, we can see the feeding artery from STA penetrates through the scalp and feed the falx. And this kind of surgery is quite easy to do. We just need to identify the drainage vein to protect before we disconnect the fistula. And then disconnected the adhesion between the arachnoid membrane and the dura, and exposed the fistula. The arterialized drainage vein can enlarge a lot, and so we need to coagulate it gradually. And after that, we just do the disconnection. And for a typical type 3 or 4 anterior cranial fossa DAVF, the surgery is quite simple and just needs about 20 minutes. So this kind of surgery is what I did before I can handle ruptured aneurysm clipping. I can handle this kind of surgery, so it's quite easy. And after that, we can remove the hematoma. And this is the intraoperative DSA to check the feeding arteries, and we can see we just need to cut the drainage vein. It can achieve a cure of the disease. So this is the right IC, and left ECA, and left ICA angiography. So for the microsurgical management of the anterior cranial fossa DAVF, there are two different point of view. That on the right side is what Michael Lawton said on hemorrhagic and ischemic stroke. It said that we just need to dissect the drainage vein, but we do not need to excise the dura involved the fistula. But on the other side, on the other hand, someone may address that we need first to cut the feeding arteries, and until the drainage vein turns dark, then we can cut the drainage vein. That's two different points of view on how to deal with the fistula under microsurgery. But the left side, I think, is old-fashioned, but it's reasonable after in the slides. But nowadays, people like the minimally invasive treatments more and more, and patients always ask doctors whether I can choose endovascular treatment to this disease. So the most recent published endovascular treatment for anterior cranial fossa DAVF, that's a multicenter investigation from USA and Turkey, and they totally include 23 patients in their series. We can see that overall cure rates of endovascular treatment to this kind of disease is 82.6%, but they are quite different. The results were quite different from transarterial approach and the transvenous approach. In transarterial approach, 7 out of 9 patients did not receive total occlusion of the fistula, but in patients who received transvenous approach, almost 89% patients received total occlusion of the fistula. So it seems that the transvenous approach may be better for this kind of the disease. But in my opinion, so no matter artery or transvenous approach, the most important thing is which approach can allow the microcatheter to be sent to the position most closest to the fistula. So look at our case. This is a very lucky case. The distance between the fistula and the superior sagittal sinus is quite short and no tortuous. So we can simply put marathon microcatheter through the sagittal sinus to the fistula. So it's very easy to be in position of the fistula. So we just need a very little onyx to totally occlude the fistula. So this is a very lucky guy. And to see another case, this case we can see it has a very obvious drainage vein, and the feeding artery mainly from bilateral ophthalmic artery, and the right side of ophthalmic artery was robust. And so if we choose approach transvenous or transarterial, the drainage vein is tortuous and seems very difficult to super select from the superior sagittal sinus to the venous pouch, but the ophthalmic artery seems robust and could be super selected easily. But do we need to use this transarterial approach and sometimes even use the balloon to protect the ICA, or use the pressure cooker technique to avoid the reflex? Is it safe? Sometimes because the ophthalmic artery or a smaller artery may connect with the central retinal artery, so we dare not to use a very high injection pressure to make the onyx diffuse to the fistula, because they may also diffuse to the central retinal artery. So let's see the ECA feeders. We can see the patient is very lucky to have a very robust right ECA, right MMA, and it give a rise to the Felsen artery and go direct to the fistula. So finally, we choose this kind of artery as our approach. So when you face the many choice to choose which artery to select, we usually use the artery of dura. That means artery embedded in the dura. It was wrapped by the dura mater, and the dura mater can restrict the vessel from enlarge when you injection. So after I put the microcatheter into the Felsen artery, it still cannot reach the fistula, but it's wedged in the distal Felsen artery. This once it's wedged into the artery, and it will create a constant forward pressure, and it will not reflect to the proximal segments of the artery. So it's easy to allow the onyx to infiltrate to the fistula. So after we inject some onyx, the fistula was totally occluded. So to some super case, endovascular treatment could be a nice choice. But let's see a special case of the anterior skull cranial fossa DFF. This case is similar to the last case, and it's have obviously enlarged drainage vein, and the feeders are bilateral ophthalmic artery, and also the Felsen artery originates from the ST and the MMA. But after we talk with the patient, he still decide to receive the surgery first. So all what we disconnected, but after that we can see there is still a tortuous vein located on the falx. So we suspect maybe there is a residue of the fistula, but we are not very sure. So we check the intraoperative DSA and find that the drainage vein didn't appear on the right side, but it's still very obvious at the middle. At that time, we are not sure whether this drainage vein direct drainage to the superior sagittinus in the dura, or it's drainage through a cortical vein. So we turn to use the traditional surgical technique that's cut the feeding arteries from the dura from epidural space. So we first coagulate that the enlarged tortuous vessel on the falx. Oh, sorry. And but once we encounter the feeding artery, it's very dangerous for this kind of disease. It's tremendous bleeding suddenly appeared. So it's very difficult to coagulate it from the dura. So we take some time to cease the bleeding. And then we separate from the epidural site and cut all the feeding arteries from anterior ethmoid artery and use the bone wax to cease the bleeding from the bone matter. And after that, we rechecked the intraoperative DSA and still found there are some residual feeding arteries from the ophthalmic artery, and there is still residue from the MMA. So at this time, because the bone flap is not large enough for us to cut the feeding arteries from the falx, and also it's very difficult to cut the feeding arteries from the posterior ethmoid artery. So we decide to switch to endovascular treatment. So we still choose the gold approach, the MMA approach, and put microcatheter there. And I think I used the echelon 10 and let it wedged into the feeding artery and inject step by step, but finally success in endovascular treatment. This is the follow-up DSA at 6 months after the operation, and no recurrence and residue. So just a simple summary. So when I face anterior cranial fossa DFF, I'd like to first perform the DSA and clearly understand the type of the fistula and the drainage direction of the fistula. Is it a single direction or bilaterally drainaged? And to evaluate the arterial and the venous axis, do we have a very suitable venous or arterial approach for endovascular treatments, or does the patient present with a hematoma, and whether the hematoma is large or small? After the evaluation, if the patients have a very good MA axis or very good venous axis, I will choose the endovascular treatment first, and sometimes may use the pressure cooker technique to achieve a cure embolism. And if we don't have a very good MA axis or venous axis, will not first choose the ophthalmic artery approach to perform the endovascular treatment. I will choose the microsurgery because it's easy and have a very high occlusion rate. But nowadays, if we choose microsurgeries, I will perform the intraoperative DSA to ensure the total occlusion of the fistula. If the intraoperative DSA find residue, and I will check the feeding arteries and the drainage veins to check whether it's bilaterally drainaged, and can I cut the residual drainage vein. If not, I will choose to perform the endovascular treatment. But if the patient, we don't have a very good arterial axis, and the patient don't want to do the microsurgery, I will talk about the endovascular treatment from 08 with the patient, and see whether he can receive the risk of the surgery. So, in my opinion, I think the anterior cranial fossa DFF are most type 3 or 4 fistulas. So the micro surgery can achieve almost 100% cure rate, and intraoperative bleeding is not common, and they enjoy the sense of smell. So it's the most disadvantage is big incision, and some most often we need to. That's the disadvantage. Used endovascular treatment to treat this kind of disease. I will first evaluate the MMA approach or venous approach. That's my limited experience to this kind of disease, and I'm very glad to and welcome the discussion from the colleagues. Thank you so much.
Thank you for that great talk, showing all different options of treatment of this disease. We are in an evolution in this, and the evolution, I think, is both microsurgical and endovascular. I think the endovascular evolution is faster because it's newer. There is still microsurgical, I think, evolution happening with this. The biggest thing, as you said, is the big incision. You need a bicoronal incision to get to microsurgical of this. But if you put it behind the hairline, you don't shave a lot of hair. I do it without any hair shave. Very part the hair, and I do a very nice zigzag incision so that it doesn't separate the hair, so it's cosmetic. And then when I come down, I do a smaller craniotomy. I don't do a big craniotomy. I kind of put it right on the sinus, go slightly on the other side of the sinus, and then if I have just a vein connecting the fistula, then I will do it. But a lot of the times when there are bilateral feeders, you'll have to resect the anterior third of the sinus with it. Then, you get a better cure. And cosmesis, paying attention to cosmesis with craniotomy on someone on the forehead, and management of the frontal sinus. But, we have a lot of expertise over the years to do all of this very, very well. And it has 100% cure. But as is always, can we do something without opening someone's head? It becomes the question. Because if we have, all of us, one of us have a cranial, say a fistula, we all say, hey, can you do this without opening my head, right? For each one of us. So that's something to think about when we have a patient too. And I think our expertise with transvenous embolization, and an ability to catheterize very distally, use pressure cooker techniques, use intermediate catheters to achieve stability in distal arterial circulation, use microballoons to prevent reflux, and more controlled experience with Onyx has increased the ability to treat these fistulas. So in my opinion, a lot of the times, as you said, I actually come endovascular, and I do this technique where I kind of tame the fistula first, right? Sometimes we came, even if the ophthalmic is the bigger feeder, you come through the smaller feeder, as you said. Can we get closer? Can we decrease the flow through the fistula first? Because when you're doing transvenous cure, if you really think about it, you're doing retrograde embolization against the flow, right? So a lot of the times, if you decrease the arterial supply from the arterial side, it affects and increases your ability to cure from the transvenous side. So it's an important thought process where, I think I first try to see how much of the arterial flow I can knock down before I go for a kill from the transvenous side, rather than, hey, I'm just going to first take transvenous because you're still fighting against all this arterial flow coming through the fistula, if that makes sense. And having an ability to do all of this, transarterial, transvenous, to do microsurgery. And sometimes the thing you talked about, where there are posterior moral feeders coming, you have a big venous pouch, endoscopy during microsurgery helps us identify these feeders, and then intraoperative ICG helps us take care of these patients too. So a lot of tools and a lot of expertise is very important, and then choosing the right thing, how to be minimally invasive and cosmesis.
Very well said. Thank you very much. If there are any questions from the audiences, we can have it now. Yoshimura Sensei is still with us. Sensei?
Oh, yes, I have been listening to his lecture. Wonderful. Wonderful treatment. You have many options to treat the patients, including very difficult cases. So you said that there is a chance to treat this kind of shunt from the transvenous approach. But I'm so personally worried about the rupture of the shunt by insufficient embolization. So how do you select the patient for transvenous approach?
Yes, I only choose the transvenous approach that the drainage vein is not enlarged very much, and they have a very short distance from the fistula to the superior sagittal sinus, because this kind of fistula most of them are type 3 or type 4. So the vein is a cortical vein, so they are weak. They are prone to rupture. So I will not easily to choose a transvenous approach. I prefer the transarterial approach for a super case to use the MMA. That's what I most like. Only a very little proportion of patients that have a very good transvenous access, I will choose the
Okay.
transvenous. Yeah.
Thank you.
Thank you.
Thank you very much. If there are no further questions, I think we can hear the final remarks from our chair.
Thank you. Just for Dr. Yoshimura's question, it's very important to have your microcatheter wedged at the fistula, right? It's fistula site. If you can do that, then you can do a transvenous embolization. The problem is when you have a big venous pouch and you think that you can embolize the fistula from a distance, right? That you cannot do, because if you pressure cooker or do anything, you're going to rupture the vein. If you can take the microcatheter and wedge it right at the junction of the arteriovenous connection, then you can do a transvenous fistula. And I think decreasing the fistula's flow through the transarterial road, even if you didn't cure it, helps in that cause and your ability to treat it and cure it transvenous. Okay. Thank you, everyone. I appreciate everyone being here, and congratulations, Dr. Paling. That was an amazing presentation with difficult cases.
Thank you very much. We'll now call it a day. I'll close this officially now. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to thank both speakers of today, Professor Charles Matuk and Prof. Li Piliang, as well as the chairs, Prof. Shinichi Yoshimura and Prof. Shabarish Natarajan, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and as of now we have around 540 people who have joined through various channels on YouTube, WeChat and Zoom. And special thanks to my co-host Dr. Liu Bun Singh, who has joined me from Malaysia today. So we'll close this officially until we all meet online again. It is bye bye from all of us. Thank you very much for joining.